Today we'll be discussing the topic of intrauterine growth restriction. So first of all, let me introduce you to the content, to the outline of this entire discussion. We'll first of all talk about the definition and significance of intrauterine growth restriction. Then we'll talk about the common causes of intrauterine growth restrictions. Then we'll move on to the pathology and time of insult and diagnosis, and then finally management. So we have to start our discussion by talking about the definition, obviously. So the definition of IUGR is that the estimated fetal weight should be less than the 10th percentile of that population at a given gestational age of, let's say, for example, 24th week gestation. And why do we call it estimated fetal weight and not fetal weight? Well, the reason is simple. The fetus is inside the mother. So if you want to measure the weight of the fetus, one way would be to take out the baby from the mother's belly and put him on a weight machine and then put it back, which is clearly very impractical. So what we do instead is we use ultrasound to take some measurements, which we'll refer to later as biometric measurements, and then we use these to calculate an estimated fetal weight, and then we compare this estimated fetal weight to the rest of the population, and we figure out whether it's too low to be considered as normal. So the reason we have restriction in the growth of the fetus is that we know that the fetus grows inside the mother by using nutrients and oxygen delivered to it by the mother. So now we're going to talk about the common causes of IUGR. As you can see, the causes are divided into three groups: the maternal group, the placental group of causes, and fetal group of causes. So we're going to divide them one by one. We're going to talk about each one of them, because as you can see, any problem in this interface of the communication between the mother and child in the transmission of the nutrients can cause intrauterine growth restriction. So we'll talk about first the maternal conditions. So the mom. Beautiful. Right. So another first thing to remember is any substance abuse. If the mom abuses any substances like smoking, cocaine, heroin, those can directly harm the fetus. Second thing, if the mom is on any medications like, let's say, warfarin, anticonvulsants, folate antagonists, any drug which can be toxic to the fetus can result in IUGR. Thirdly, extremes of age. Extreme age. That means if the mom is less than 16 years old or if she's older than 35 years of age, that both of these can increase the risk for IUGR. What else? Another thing that can affect the child is if the mother suffers from any medical diseases, right? So this can include diabetes, this can include hypertension. All of these will again could result in IUGR. And lastly, if the mother's nutritional status is not good enough, which means that if she's underweight, right, or if she's nutritionally deficient, they do have a high risk of their fetus having IUGR. And I want to mention at this point of time is that there is a certain type of specific growth restriction that maternal factors can cause, which is called as asymmetrical growth restriction. Let's explain what this means. So what is asymmetrical growth restriction? Asymmetrical growth restriction is when the child's growth restriction is asymmetrical. What do I mean by that? I mean that, let's imagine this is a child, right? This is a child, his arms, nice little plump arms, legs, right? So this is a kid, and you can see that it's mostly symmetrical. His legs are in proportion to his head. But what happens in asymmetrical growth restriction is that one part of the body remains the same while the rest of the body just shrinks or is growth restricted. So that could result in a child which would probably look like this. Obviously, I'm exaggerating the diagram for the purposes of this drawing, but as you can see, the head is abnormally large as compared to the body. This is what asymmetrical growth restriction is, and maternal causes are one cause of resulting in asymmetrical growth restriction. Keep this in mind because later on we'll be discussing something called symmetrical growth restriction, which you can imagine the child child's growth restriction is restricted uniformly. So even though, so like for example, if this is the normal child here, an abnormal child with symmetrical growth restriction will probably look like this. So his entire body is growth restricted, not just the abdomen, like in this case. So now that we have discussed the maternal causes, we'll move on to the placental causes. So the placental causes, first, let me tell you that even the placental factors will result in the asymmetrical growth restriction, right? So which is the only one which is the left, which causes symmetrical, is the fetal causes, which we'll come to at the end. But yeah, the fetal causes are the ones which result in a symmetrical growth restriction. Now we'll discuss the placental causes. Number one, firstly, placental pathologies resulting in undernutrition of the fetus can cause this. For example, placental infractions, right? Placental pathologies. Placental infractions, there is something called twin-to-twin transfusion syndrome, and any placental pathology can result in IUGR. The next thing that can result in this is uterine pathologies, right? So what do I mean by that? What I mean by uterine pathologies is the fact that the placenta has to implant into the uterine lining once the time is right. So if there is, let's say, a fibroid in the uterus before the placenta implants, that fibroid will prevent the placenta from implanting, and this could result in, again, less nutrition being passed on to the fetus, and we could again have IUGR. Thirdly, if we have genetic defects in the placenta. What do I mean by that? What I mean by that is, let's take a disease which is called confined placental mosaicism, in which what happens is the placental cells are actually different from the cells present in the fetus. So these are placental cells and these are fetus cells. Normally, they both are supposed to be similar in composition. Why? Because both of them originated from the same zygote. But in this case, what happens is placental cells are, let's say, triploid, while fetus cells are diploid. So this results in a discrepancy, and what this could result is in inefficient nutrition transfer between the child and the placenta, and we could result in IUGR. So yeah, these were the placental causes. And now finally, we'll move on to the fetal causes. So now we'll be talking about the fetal causes. So the fetal causes, first thing I've already told you, it causes symmetric growth restriction, right? So the whole baby as a whole is affected. And so that if the baby normally looked like this, a symmetrically growth restricted baby will look like this. So the whole body is affected. Not that the head is not affected, but the arms and body shrink. That is the case with the maternal causes as well as the placental causes. So now that we've understood that, I'll talk about the fetal causes. The fetal causes, number one, females are affected more than males. So secondly, any congenital or structural pathologies of, let's say, for example, trisomy 13 or 18, any of those can even result in fetal causes of IUGR. Next, we have the torches infection. Any infection during the antenatal period can again result in IUGR, and let's say multifetal pregnancies. What that means is you have twins, you have triplets, and obviously both or all three of them will try to compete for the same blood supply, and this could result in less nutrition to one of them. Now that we're done discussing the causes of IUGR, we can move on to how the early insult is different from the late insult. What I mean by that is, let's say this is the entire pregnancy, right? It is from the beginning till the end. So if the insult happens during the early pregnancy, it has different outcomes as compared to if the insult occurs in the late pregnancy. So let's talk about how that is different. Generally speaking, insults which are going to take place in the earlier pregnancy are going to be much more dangerous to the, you can say, to the fetus and to the overall mortality and morbidity as compared to late insults. It's mostly because in the earlier pregnancy, the fetus is undergoing organogenesis and other important processes which are vital for the patient's survival, for the fetus's survival, as compared to late pregnancy where things are actually starting to finalize for the child. And so now we're going to discuss how that differs. So let's first start by talking about early pregnancy. In the early pregnancy, normally the fetus's cells are undergoing hyperplasia. What that means is the number of cells is increasing rapidly. So if the number of cells is increasing rapidly, so that means any problem at this point of time can result in irreversible loss of cells, and it could lead to irreversible loss in the organ size and function. And it is important to also understand that early pregnancy causes are mostly due to the fetal factors that I mentioned before. Right, so those are the early causes that can result in the intrauterine growth restriction. On the other hand, if we talk about the late pregnancy causes, in the late pregnancy, normally the fetus does have sufficient number of cells, and once these cells have been formed in the late pregnancies, they undergo hypertrophy. So those same cells that were already present, they just increase in size. So any problem at this point of time will result in decreased cell size alone, which is still more responsive to treatment and is not as bad as an early pregnancy insult. And you must remember also that at this point of time, the common causes which cause IUGR are utero-placental problems. So the problems that I mentioned to you before, among them the utero-placental pathologies are more common in the late pregnancy. So now that we have understood how the time of the insult changes the baby's risks for IUGR or the morbidity or the mortality, the next thing we have to tell you is the complications that IUGR can cause. So once we know that the baby is restricted, but how does that matter? Why are we so worried about the restrictions, about the growth restriction that the child suffers from? It's because it causes complications during the fetal period, and it causes complications during the neonatal period, which is once the baby is born. So in the fetal period, the complications which can result is, first of all, death. Second, asphyxia. Third, acidemia. And lastly, intolerance to labor, which means that during the stress of delivery, the fetus will not be able to tolerate that, and he might actually die. All right. And as for the neonatal period, once the child is born, the problems which can happen are, let's say, polycythemia. The reason for what polycythemia is it's an increase in the concentration of RBCs in our system. So why that happens is to compensate for the lack of oxygen that the baby is receiving. So if the baby is receiving decreased O2, the body responds to that by increasing the concentration of the RBCs and the hemoglobin concentration, so that it can make up for all that low oxygen that the child is not receiving. Right. This is the reason that we can have polycythemia. We can also have hyperbilirubinemia. Again, same reason, because we're having polycythemia, there will be increased breakdown of hemoglobin, and that hemoglobin will be metabolized to bilirubin, which will increase. And next thing we can have is hypoglycemia, which is low glucose. Why do we have low glucose? Is again because the child is receiving less nutrition, and the child will not have enough fat stores in their body to actually compensate for low glucose. So that is a reason that we will have hypoglycemia as well. We can also have hypothermia, decreased temperature, which is the reason is the same again. The child does not have enough fat stores in the body to generate heat, and again we'll have decreased temperature, hypoglycemia, and hypothermia, sorry. And we can even have apnea. Apnea makes sense also because we're not receiving enough oxygen, the child will cease to breathe. And this is the same reason that we also have respiratory distress. Right. So all these are complications which can result from intrauterine growth restriction during the fetal period and during the neonatal period. The next thing that we have to discuss is diagnosis. So the diagnosis, we'll be talking about four things in diagnosis. We'll be talking about how to screen for IUGR, how to confirm IUGR, what are some direct studies that we can do which are invasive to make sure that the child does have IUGR, and how and possibly do investigations which can affect our management. And finally, the Doppler, which is again an investigation which is of critical importance in this case, especially because our management and the patient's prognosis depends on how the results of the Doppler are. So we'll start off by talking about a screening. So to screen for IUGR, the screening tool we use is something called fundal height. So the screening tool that we can use is something called the fundal height, which isn't the most accurate test that you can use, but it is often enough to point us towards the right direction in terms of the diagnosis. How the fundal height is measured is like, imagine this is the belly of the pregnant mother, and this is her pubic bone. And during a physical examination, we find out that the fetus, we can feel the top of the fetus till this point. So we measured this distance using centimeters, and we correlate that with the gestational age. So after 20 weeks of pregnancy, often your fundal height will be equal to that same number in centimeters. So if the child is 22 weeks, he is supposed to be 22 centimeters long in your fundal height examination. So if there's a difference of more than 2 centimeters between these parameters, of, let's say, if the child is at 24-week gestation, but your fundal height that you measured comes out as 21 centimeters, which is a difference of 3 centimeters, that means we need to do further diagnostic investigations to rule out any possible causes of any problems. Like one of them could be intrauterine growth restriction. So then the confirmatory investigation is what? The confirmatory investigation then is ultrasound. Right. So in ultrasound, what are the things that we check? Previously, I mentioned to you that we have to calculate estimated fetal weight using biometric measures. And these are those biometric measures that we have to do now using the ultrasound. So what are those? There are 4 of them. And namely, there are, first of all, biparietal diameter, right? And there are head circumference, abdominal circumference, and femur length. So these 4 are the main measurements which we can then use to estimate the fetal birth weight, and we can then compare it to the percentile of the population, and we can talk about the definition that we have already mentioned. So especially the abdominal circumference is very important in this case, because we can, if the abdominal circumference is within normal range, then we can kind of confidently say that the patient does not have IUGR. And this is the idea behind the ultrasound studies. Next, we would like to move on to the direct studies, which I mentioned above. If you notice, these are the direct studies. And we're going to talk about the direct studies. Now, what are the studies which are a bit more invasive than the ultrasound and which can give us a more confident diagnosis? So these are the examples of the direct studies that you can perform. One is amniocentesis, chorionic villus sampling, percutaneous umbilical blood sampling, which may all help in IUGR confirmation, but obviously we do not prefer them considering how invasive they are. The next thing that we need to talk about finally in the investigations are the Doppler studies. So we use Doppler velocimetry once IUGR is confirmed using ultrasound. The purpose of this test is to assess perinatal outcome of the fetus, or in other words, how the fetus is adapting to the decreased growth and nutrition that he's receiving. So what we do is we examine the artery which is carrying deoxygenated blood away from the fetus. What is that artery? That is the umbilical artery. Right, so we check the flow within this artery using Doppler, and what the 2 values we take is number 1 systole and the other diastole. So systole and diastole, and what we do is we make a ratio called systole over diastole. Right, and normally this ratio should be less than 2:1. So the systole should be 2 and the diastole should be 1. In ratio, that means if it's 100 here, it should be 50 here. That is 2:1. But any time that the ratio becomes more than 2:1, if it becomes 3 4:1. If it becomes 4:1, that means that we have a problem which is serious. So you might have to take more serious measures to save the fetus in this scenario. Another vessel which we need to mention is the middle cerebral artery. Right? So the middle cerebral artery supplies the brain. And so since supplying blood to the brain is a priority, what our body does is it shunts blood away from the organs like kidneys and increases blood flow to the middle cerebral artery. And this, the fetus's body is doing this so that it is able to compensate for the decreased oxygen that is being given to the fetus. And thus what you see is an increase in the diastolic and blood flow velocity in the middle cerebral artery. So what you see increase in diastolic blood flow, and you also see an increase in the overall blood flow velocity in the middle cerebral artery. Right. Another vessel which I should mention in this case is another vessel that we check is the ductus venosus. This vessel is actually carrying oxygenated blood from the placenta to the heart. Right. So we also use it to evaluate IGR, and abnormal flow through this indicates that the child is clearly not receiving enough oxygen, and this also indicates to us very poor prognosis for the fetus. Right, so finally we're going to talk about the management of IGR. Firstly, the goal is to deliver the most healthiest possible infant at the most optimal time. To be able to do this, what we need to do is we need to create a system of follow-ups where we'll be using fetal biometry, the measurements that I mentioned before, using ultrasound. We have to use those and they're performed every 3 to 4 weekly, and checked whether the baby is progressing, is it becoming better, is it becoming worse. And the fetal surveillance which we'll have to perform will include fetal movement counting, non-stress testing, biophysical profiles, and even Doppler studies. So now we have to decide whether we want to deliver the child or not, according to what you do that. So you deliver the child if the serial biometry shows worsening Doppler growth study. So if the situation is worsening, you deliver, because you don't want the child to go through more complications during their fetal life, and you delay the delivery if all biometry values indicate normal values. So if the values are normalizing, that means the fetus is probably growing well. So then you delay the delivery and you allow the fetus to grow further. And once the child is born, it is important to prepare for any possible respiratory distress, hypoglycemia, and other complications, which I mentioned in the previous section, I think. All right, that's about it for the video. If you felt that it was useful, go ahead and subscribe to the channel, so maybe if in the future, if I upload anything, you can be informed of that. Other than that, goodbye, good luck.